Hi everybody, welcome back. It's part two of chapter 14. We're going to be talking about the secondary assessment of the trauma patient. We talked a little bit about um, the secondary assessment of the medical patient last, and so this time we'll talk about the trauma patient. Share my screen here. All right, fantastic. One second. All right, let's jump into it here. So, secondary assessment of the trauma patient. Remember, we've already done our primary assessment, we've done our ABCs, we have figured out what our priority is going to be, at least to start. There, we've determined the patient's chief complaint. Um, there, um, so we're working our way through, and again, this is for the trauma patient. So this is somebody that's been injured, and this is how we'll do our assessment of them. Just an important note to make that injuries obviously can be very minor, something like a paper cut, um, a stubbed toe, whatever it might be, to something very severe. Obviously, somebody with like a head or abdominal or chest injuries or multi-system traumatic injuries obviously can be quite severe. And to figure out how severe they are, how serious the situation is, there's things to consider. One is the location. We see like head injuries, neck injuries, chest injuries, abdominal injuries. All of those can be very serious because of the underlying organs there. You can even have severe injuries to the extremities too. So you don't think that just because it's an extremity, it can't be injured severely. So location of the injury or injuries is important. Their mental status will give us an idea of what's going on. So if they have a head injury and they have an altered mental status, that's going to make this a more severe patient than otherwise. Or if they have an injury somewhere else and we have an altered mental status, that's telling us that things are going on, and this is inside the body, and that this is probably more serious than we at first suspected. So mental status, as we've talked about, is always a good indicator about how serious things are or not. We need to worry about their airway. Again, as we've said, if we don't have an airway, we don't have a patient. So we got to make sure the airway status is good, that their vital signs are within normal limits or close to them. And then also in vital signs, hopefully the trend, if we're taking them multiple times, we can see if things are trending up or trending down with things like getting better or getting worse. So vital signs are obviously very important. Um, the mechanism of injury is something to consider about how serious somebody may or may not be injured. Um, mechanism of injury is how somebody got hurt. You know that, right? It's how somebody got hurt. So obviously, how people get hurt can vary, and some things are more serious. So let's say, stepping off a step onto like an icy sidewalk and you twist an ankle, right? That's that would be the mechanism there for somebody. Not too bad, right? Not too serious, but if you compare that to somebody saying getting hit by a bus, right? That's obviously one is much more serious than the other. So considering the mechanism of injury is important. It's crucial to figuring out how serious something is. And then a patient's age or pre-existing conditions can obviously change how serious things are or not. Now, we talked about this before with age. Let's say, for example, you have a patient that fell down 3 steps. Who would you be more worried about? A 17-year-old or a 70-year-old? Just because of the age, it makes things worse there, right? So patient's age and any pre-existing conditions, medical conditions, things like that can obviously make things worse. All right, so let's talk about trauma patients with minor injuries or they're low priority patients. Right? Somebody that we can take our time with. There's not a threat to their life immediately. They're a patient like that. So our assessment with these folks is going to be based on their chief complaint, about where they're hurt, and like which area is more painful, or the mechanism of injury, right? Whatever area that they say hurts, or wherever the mechanism of injury would indicate that there is an injury at that spot. So we're going to focus on what they tell us is wrong there with them. And we'll get that by, that's obviously their chief complaint. What they tell us is happening is their chief complaint. Right? What's wrong in the patient's own words. And we'll conduct a history of the present illness to get the information on how it occurred. So now, obviously, we're talking about injuries here. Okay, so we can change this to say conduct a history of the present injury rather than illness there. But it just means we're getting a history of what happened before we get there on scene. So to determine the chief complaint, we've already gone over this. It's real simple. Ask them. Ask them, well, can you tell me what's going on today? And they'll tell you their chief complaint. So in order to conduct a history of the present illness, we got to ask them questions like, and figure out things like the nature of the force involved. So when somebody gets hurt, a force is applied to their body. No matter how they're hurt, a force has been applied to their body somehow. You don't just get injuries just standing there, nothing happening. Something has happened to the body. A force was applied there. So we got to figure out what the force was, right? Did somebody get hit by a bus? Did they fall down some stairs and their momentum and falling, gravity and all that? Their body hitting against the floor or the stairs, that force applied to the body there. So we got to figure out the forces involved. How did you get hurt? The direction and strength of the force. Where did you get hit? If something hit you, where did it happen and how strong was it, right? Was the bus going 2 miles an hour or 40 miles an hour? Was your patient punched in the head by a 4-year-old or by a 40-year-old? Right? There's the difference there. So we got to figure out the direction, where the force came from, how it was applied to the body, and how strong it was, right? Was the patient using any protective equipment? Were they wearing their seatbelts? Did the car have airbags? If they're riding a bike or something, did they have a helmet on, or like elbow pads, or whatever it might be there? So did they use protective equipment, right, that could minimize or lessen injuries? Actions taken to prevent or minimize injury. Again, this is like wearing equipment, using proper safety equipment, harnesses, tools, anything like that, right? So any kind of actions that might prevent that, make things worse. And then we're going to figure out where on the patient's body they're hurting, okay? Areas of pain and injuries that are resulting from the forces applied to the body. We'll have to figure out where those are. In doing a physical examination, let's talk about that. This is where we're actually going to be looking and touching the patient. Now, with a conscious patient, right, they're conscious, they're awake, they're communicating with us clearly. What we're going to have to do is we're going to assess the areas that they tell us they're hurting. Really simple, really simple. I hurt my arm, okay? I'm going to look at this person's arm. I'm not going to look at their toes or their leg, based off of if it's a minor injury and their chief complaint is their arm, I'm not going to look somewhere else. Now, mechanism of injury may point you to other places, right? If like somebody fell down the stairs and tumbled and they say, oh, my arm really hurts. Well, maybe multiple points on their body made contact with the stairs as they're rolling down the stairs. So that might get you and give you an idea that, all right, maybe I know the patient is saying their arm hurts and we're going to check that out first, but maybe I'm going to check other places too, just in case. There are things that are called distracting injuries, and so maybe one injury hurts worse than others, and so they don't know about it, right? Maybe they've got a broken humerus, right? Man, that's really got to hurt. But they don't notice the other pain from any other injuries that they do have, because the injury to like the broken humerus hurts that much more. So um, it's always important not only to take the patient's chief complaint into account, obviously we have to on every call, but doing your detective work, thinking about that mechanism of injury, forces that could have been applied to the body, and say, all right, well, you know what, because of the way you were injured, it tells me that there's a possibility at least of more injuries coming, or in different places rather. So we got to look. So when we're doing these assessments, obviously we're going to look where the chief complaint is telling us to look. But we also have to remember that we're doing detective work here, and that there may be other places that we need to look. So mechanism of injury is going to give us that idea. We have 3 techniques to do a physical exam. They are to observe, to palpate, and to auscultate. We see to observe means to use our senses. We're going to look at the patient, we're going to listen to the patient, maybe we're going to smell the patient, right? Maybe we can smell something that gives us a clue to what's going on. So we'll use our senses there. So palpate means to touch. We're going to touch around injuries and the injured sites themselves. And then we're going to auscultate, which means to listen. So we're going to listen to certain things. Not all things. Obviously, if someone's got a broken arm, I'm not going to listen to their arm. Right? So, but those are the 3 techniques that we're going to use. We're going to observe with our senses. We're going to touch and feel them and palpate. And then we're going to listen. We're going to auscultate. So we're going to observe. What are we going to look for? What are we going to use our senses to observe for? One of the great things about the human body is that it's symmetrical. Things are the same on one side as they are on the other. So we can observe for abnormalities in symmetry, which means, let's say somebody hurt their hand. Let's just say that they hurt their hand somehow, right? And we got to know if it looks any different than it normally does. Well, we probably don't know this person. We've probably never seen this person in our lives, things like that. So the easiest way to be able to do that is to take the injured hand and compare it to the other one. Is it the same? Is one more swollen? Is one discolored? Or is it misshapen compared to the other one? So we're going to look for abnormalities in symmetry. Usually those abnormalities can point us to those injuries. Observe for color. We're looking obviously for abnormal colors. Is it pale? Is it is cyanosis? Is that happening there? And so bruising, any kind of discoloration away from normal. Shape, again, if it's an abnormal shape, right? If it is does your patient's arm now have a second joint, right? They broke their humerus, so now does the arm take a right turn right here, and then there's the elbow, right? So if part of the body is looking like it's got a new shape to it, maybe it tells us that there's an underlying injury. Movement. We're going to look at if they have the same range of movement that a person should have, right? Can I move? Somebody hurts their shoulder. Can they move their arm? Can they support the arm's own weight, holding it around? Can they only keep it close into their body, right? Range of motion, range of movement. We should all have an idea of what normal is, because hopefully we can all move in normal ways there. So movement is another thing to take a look at for an examination. Can you really hurt your fingers? Can you wiggle them for me? How does that feel? Can you wiggle? Can you move it? How does it feel when you move it? Those type of things. So movement is good to observe for. When we palpate, that means we're feeling, right? We're touching our patient now. We're going to be palpating for any abnormalities in the shape, right? Of the area that we're palpating. We're feeling for temperature. Is it too hot? Is it too cold? If there's a loss of blood, to an extremity. Let's say somebody breaks their humerus, pinches the radial artery there, or excuse me, the not the radial artery, but pinches their artery and the brachial artery. Pinches the brachial artery, and we're not getting any blood down to the fingertips, right? We have a break here, pinches the artery, but we're not getting blood down to the fingertips. Think these fingers would be cold, or would they be hot? No blood, no body heat, right? These are going to be cold. So if that was the case, so feeling changes in temperature can be clues to things there. So we'll palpate for that. Texture. When you feel somebody's skull, it should be kind of nice and hard. Maybe you feel their natural lumps and bumps, but it shouldn't feel like Rice Krispies sound, right? We don't want that crepitus there. So texture is there. Sensation. Can you feel this? Again, let's go to broken arm again, right? Say they got a broken arm, and we're feeling down here. Can you feel this? Touching you. Can you feel this? Right? Do you have sensation down here? Can you feel what I'm doing with your fingers? Right? Maybe they pinched a nerve or bruised a nerve, something like that, severed a nerve. When we listen, we're going to be listening basically for breath sounds. That's all we're really listening for here. And we're going to listen for decreased breath sounds or absent breath sounds. We can also listen for noises, abnormal noises. Gurgling in the airway can be something that we're going to listen for. Rales, bronchi, all types of things like that. Lots of different sounds we can listen for. All right, here's part of the physical examination that you are going to have to know by heart. Right? And it's called DCAT BTLS. You're going to have to know what each of these letters stands for, all right, and to be able to do it quickly. What DCAT BTLS means for is it is an anagram to let us know what we are looking for throughout the body when we're feeling the body. Okay, when we're palpating somebody, when we're observing them, this is the list of things that we're looking for. What it stands for, and you should be able to say this. You should be able to say this easily. What DCAT BTLS stands for is deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. You should be able to say all of those things. Okay, we need to know what we're looking for. All right, deformities, contusions, abrasions, punctures, and penetrations, burns, tenderness, lacerations, and swelling. We need to know those things. Let's go through these real quick to make sure that we know what they mean. Contusions, whoops, what did I do? Contusions, big fancy word for bruising. Okay, contusion is bruise. Abrasion, another medical term here for a scrape. Punctures and penetrations, that's obviously when an object has penetrated through the skin or punctured the skin and gone inside the body. Whether it stays there or not, it doesn't matter. It's still a puncture or penetration. Burns, tenderness. When you touch a site, the patient feels pain. Okay, it's tenderness. Lacerations is a medical term for a cut, and swelling is obviously swelling. So DCAT BTLS, whenever we're doing a physical examination on somebody, this is what we're looking for. Deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. Right? You need to be able to say all of that. Get it in your head that that's what we're looking for. Right? You can't be forgetting these things because these are clues. This is like the pathway, the correct pathway to follow in searching for the clues about what is wrong with our patient. Right? So we can look for all of these things anywhere in the body. We'll talk about specific things to look for at specific parts of the body, but head to toe, whenever we're doing a physical examination, wherever on the body that you're examining, you're also looking for these things. Right? deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. DCAP BTLS. Okay. Need to know that. Can't put too fine a point on that. All right. So after we've conducted our physical exam of the patient, we'll get our baseline vital signs and get a medical history for them. With a medical patient, obviously it goes a little differently, right? We get the history and then the vital signs, right? Here we'll do the physical exam, then we'll get the vital signs, and then we'll get their medical history after that. Excuse me. So after we do the physical exam on a trauma patient, then we'll get these vital signs and we'll get the medical history. Obviously, they're not as important. I mean, with a trauma patient, obviously, vital signs can be extremely important, and we'll probably have to get them done pretty quickly with some of these patients. But it's not the number one step because we need to get the physical assessment done on somebody that's hurt. We need to get that done first. We talked about sample, right? So past medical history, right? And we want this even on a trauma patient. I want to know that if that old man that fell and broke his shoulder when he was shoveling snow, I still need to know, like, you know, has he had a stroke? Is he on anticoagulants, right? Is he on blood thinning medication? Does he have a history of falling? You know, things like that, right? We need to know whatever their past medical history is. So we use sample, which is signs and symptoms, allergies, like we talked about, medications, prescribed, over-the-counter, prescribed but not taken, pertinent medical history, last oral intake, and events leading up to now. So, and then that's the framework of questions, but obviously you want to use that with every patient, but obviously, as we talked about, you can use your own questions in there to clean things up, pick a little bit more information. Oh, he said something interesting here. Let me ask a follow-up question to get a little bit more of that information out of you. So you can use your own questions to clarify things, to pull more information out of the patient. There are things like that. Right? But sample is the basis for which we're going to do that for our past medical history. Since we've gone over sample, you guys know this, right? So make sure you have these questions down well. No sample. We use this for every single patient. So make sure you know these signs and symptoms, allergies, meds, pertinent medical history, pertinent past history, last oral intake, and events leading up to the illness. Okay, so let's talk about putting on a cervical collar, or C-collar, as it's known about. You guys have seen these. These are the collars that go around somebody's neck that prevent them from turning their head or lifting it up and down. If it's applied properly, it will be straight on. It will keep their head in a neutral position, looking straight forward, not cocked off to the side, back, front, anything like that. All right, so we may need to use that. Now, cervical collars don't belong on everybody. We'll apply them if the mechanism of injury, their history, or their chief complaint tells us, or the symptoms tell us that we need it. If somebody has had a history of, cervical spine surgeries, right? They've had previous injuries there before, and they were in fender bender, and they got whiplash, and the guy's reporting a lot of pain back there. Well, maybe because of the past medical history there, we're putting the collar on, right? Maybe the mechanism of injury was very low, but because of like a parking lot, bumper to bumper, and a little bit of whiplash there, but maybe that mechanism of injury was slight enough where we now have a serious problem there. So if somebody's rolling over in a car, your head's probably bouncing all over the place, things like that. Any force applied to the head, neck, or shoulder level, or anything above the shoulder level, a lot of force applied to the head, that area, as part of the mechanism of injury, you should probably be using one of these cervical collars. Another symptoms that could be indicative of using that, any neurological deficits. So they can't move their extremities, their arms and legs. They feel tingling or numbness in any of their extremities. Those would be a sign or symptom. Midline tenderness, which is tenderness straight down like the middle of their neck, down their spine there. That could be done as well. When we get back in class, we'll size the collars. This is showing you how we're going to measure the patient's neck, how we're going to apply it, and things like that. But we will do this in person in class. I'll at least make a video for you guys. So we'll just go right on. All right, so that was basically finishing that up. That was basically, it's a patient with a very minor injury, right? Very low mechanism of injury. It's a low priority patient. So let's just say it's your stub toe call, right? We're going to get in, we're going to do a primary assessment like normal, like any patient. We're going to ask them what's wrong. They're going to tell us, I stubbed my toe, whatever it was. And we'll do a focused assessment on that area, right? I don't need to do a head to toe. I don't need to feel all over their body because the toe. So we'll look at that. We'll observe it. We'll palpate it. We don't have to auscultate to a toe, anything like that. We don't have to listen to toes. We'll do that, and then we'll get the vital signs and their history there. Now let's talk about trauma patients with serious injury, or they're multi-system trauma, or a very high priority patient. And just to make sure we're clear, multi-system trauma patients have injuries to multiple parts of their body. So there's multiple organs involved in possibly being injured and things like that. So maybe there's an injury to the head and the chest. Or maybe they've got a couple of long bone fractures. So basically any of the longer bones in the extremities, things like that. There's going to be multi-system traumas. They are immediately high priority patients. Their condition should be worrisome if you ever have this patient, multi-system trauma patient. For these folks, we're going to probably be taking C-spine right at the end of our scene size up there, right? We do our scene size up, we're looking at the mechanism of injury, and if we think that because of the mechanism of injury, it could be forces that have been applied to the head, neck, or basically anything above the shoulders there that could cause injury, then we're going to manually stabilize the head, right? We're going to hold the patient's head. We'll be standing behind them. We're going to hold them, on the sides of their face, basically their head. That's now your head. They're not allowed to move it. You have to keep it in a neutral position, right? So that's manual stabilization. So we'll start with there. Again, we're back down to into our scene size up, right? Have we already called ALS? Hopefully we have. All right, so what this patient or this picture is showing is they're starting a rapid trauma assessment on the patient. What is a rapid trauma assessment? Real simple. It is doing a head-to-toe assessment on the patient. It takes about a minute and a half, a minute or so. We're going head-to-toe on this patient. Now, this is in the secondary assessment, so hopefully we've already found and corrected any life threats. What we're doing here, our main objective here in a rapid trauma assessment is to very quickly find the large or significant injuries on a patient, all right, head to toe. And what we're doing is we're cataloging everything we find, right? So normally, with adults, we're going to start at the head and work our way all the way down to the toes and hit, look at, touch everything in between, okay, from head to toes. And we're going to be cataloging everything. Unless we find a life threat that we didn't see before, right, we're not stopping to fix anything in this rapid trauma assessment. The only time we're going to stop to fix anything in a rapid trauma assessment is if we find a life threat that we didn't already see. That's it. So doing the rapid trauma assessment, we're going to go head to toe on a patient, and we're cataloging all the injuries that we find, from most serious to least serious, right? So like, this guy's got a broken humerus and a dislocated shoulder. Okay, that's pretty high. He's got some scrapes and some minor cuts that aren't really bleeding. All right, that's really low. All right, so we're going to figure out, we're going to find all the injuries, and then we're going to catalog them basically. And cataloging them from like most serious to least serious will give us an idea of how we treat this patient, right? What do we attack first? Do I clean up the abrasions that they've got, any minor lacerations, or do I try to splint broken long bones? Things like that. So we're gonna figure out what our priority is for our treatments in doing the rapid trauma assessment. Again, our life threats should have already been found. If we find any when we're doing this, we'll stop, we'll correct it. But otherwise, we're just looking for injuries from top of the head all the way down to the toes, right? And again, this is done in about a minute and a half to get the whole body done. These should be performed at the scene. This is a quick, down and dirty thing. I shouldn't say that it's down and dirty because we're looking for a lot of things in here. We decap BTLS along with some very specific things depending on part of the body. But it's quick. It should be thorough, but very quick. I know it's like you can either have things like, good or fast. You can't have them both, but we kind of have to do a good one, but fast, and find everything that we can here. Again, we're looking for stuff here. We're not fixing stuff here unless it's a life threat. Once we get our rapid trauma assessment done, again, this is for a severely injured patient, an unconscious patient that can't tell us what's going on. They're either severely injured or multi-system trauma, or they're unconscious, right? So we're going to do this, and then we're going to figure out a plan of care after we do our rapid trauma assessment. So we're going to start at the head with the rapid trauma assessment, and we'll work our way down to the toes. We're going to palpate the whole skull, right? So cranium, face. We're going to look at the eyes, ears, nose, and mouth. We're going to look at all of it. Okay. When we're looking at when we're palpating the cranium, we're feeling to make sure that it's intact, right? If you see any obvious malformations of the skull, right? If there's a divot in somebody's skull, you don't want to be boop, 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 poking in like, oh my gosh, feel that. His skull feels squishy. Right? We don't really exactly want to do that. We want to go over and feel everything, make sure that we're not feeling crepitus, right? Feeling bones rubbing against each other, like squishiness, things like that. With the face, we're really looking for around the airway right here. We want to make sure that all this is good and intact, right? To keep an airway open. We've got a good jawline here, right, to keep our airway open. Things are good with that. We don't want to have injuries that we could worsen by maybe putting masks on, right, or things like that. So we got to know where these injuries are. So we want to make sure we're gonna touch and feel the whole face. The ears, we're going to look for a couple things specifically there, which we'll get to in a second. The eyes, what we're looking for is bruising, black eyes, basically, underneath both of them. If somebody has black eyes under both eyes, it could be a sign of like a skull fracture. It's black eyes, it's bruising, and so it's a collection of blood that could have drained from where the fracture is in the skull down into and sits down in these soft tissues in here. So we're looking for raccoon's eyes there. Again, we're looking for the nose to be intact. We're looking at the mouth. We're going to open it real quick. We're going to look in to make sure there's no dirt, teeth, rocks, leaves, whatever it might be, that the airway is good and open. The ears, we're going to look for blood coming out of the ears, or a clear fluid that we've talked about called cerebrospinal fluid. It's a fluid that surrounds and bathes the brain and spinal cord. And if we have this clear fluid leaking out of the ears, it means we have a skull fracture. We'll learn how to do the halo test to figure out if there's any, if we have bleeding coming out of the ears. There's a small test that we can do very quick to figure out if there's any CSF in that blood as well. So it can be hard to differentiate there. So we'll teach you guys how to do a quick test for that. But blood coming from the ears, clear fluid from the ears or nose, those are serious findings there. After we've done the face and the head, right, we're going to move down to the neck. We're going to look for a few things in the neck. We're looking for any wounds. Actually, let me back this up. We're going to go down the body real quick with this performance of the rapid trauma assessment. One thing needs to be said here, I should have said at the beginning, is that, again, from head to toe, we're looking for DCAT BTLS. Deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, laceration, and swelling. I'm looking for that everywhere. Now we're going to talk about, these are the specific parts of what we're looking for here. So we've gone through the head, we're looking for DCAT BTLS plus this other stuff. Now we get to the neck. We're going to be looking for any tenderness, deformities, jugular vein distension as well. We talked about what JVD is. The jugular veins are popping out there. We're going to be looking for a stoma, just a hole cut in the neck, tracheostomy there as well. One thing I would like to add to this is that we're going to be looking for what's called step-offs in the back, and we're going to be feeling for midline tenderness. Midline tenderness is pain that the patient has right in the middle of their neck, right down where the spine is. It could be a sign of spinal injury. We're also looking for step-offs. What step-offs are is normally your spine, right? Your vertebrae sit right on top of each other like that. But if there's an injury, maybe it's stepped off like that, right? So instead of being lined up, we feel, a large, step off like that, right? Obviously, that would be a sign of an injury. So we're looking for those as well. We're also a very light sign. We're looking for tracheal deviation. It's when the trachea moves to one side. So somebody has a pneumothorax, a tension pneumothorax, or a hemothorax, or hemopneumothorax. Right? One lung goes bad, it's popped, ends up collapsing, and the other lung kind of moves off to the side. Trachea will deviate, it'll move off to the side of the healthy lung. But this is a very late sign. So we'll also be looking for that. Assessing the chest and abdomen. Actually, before we get there, after we've cleared the neck, right? We've gone and we've felt the neck, we've palpated it, we've observed it. We're going to apply the cervical collar. At this point, somebody's just been doing manual stabilization, and we're just going to apply at this point, once you've cleared the neck, we're going to put the cervical collar on should we need it. Again, we'll have a little video here of how we put the collar on. All right, once we do that, we're going to move down. After we get the collar on, we're going to move down to the chest. We're looking for things here in the chest. We're looking for paradoxical motion. That's the first thing. That's a pretty big word, pretty big phrase there, paradoxical motion. What that means is that the chest isn't moving in the same direction at all times, right? You take a breath, chest moves out and up. You exhale, and it goes down and in, right? Well, there can be injuries, for example, where the chest might move out, but part of the chest sinks in. And when the chest goes in, that part of the chest that sinks in, it comes back out. Okay? It's called flail chest, serious injury. It's where multiple segments of ribs, 2 or more contiguous ribs there, are broken in multiple places, and so it creates kind of like a floating island, and it moves opposite of what the chest does. So if you take a breath, your chest goes out, that floating island of ribs that's broken sinks in. When you exhale, it kind of pops out. That's called paradoxical motion. It's motion of the chest that is moving opposite to what should happen. So we're going to look for paradoxical motion, crepitus or crepitation. We're looking for this all throughout the body, anyways. And we're going to auscultate lung sounds here when when we're in the rapid trauma assessment. You should take a listen to a couple of breath sounds, just real quick. A couple of breath sounds right there. For this, we need to be able to see the patient's body. Right? If we're doing a rapid trauma assessment, we're doing a head-to-toe assessment on the body. It's not good enough to not look at their body. So at this point, what we're going to do is we're going to get them what's called trauma naked. I'm going to cut their clothes off if I have to. If I can get them off without hurting them, injuring them, and do it in a very quick manner, then we'll try to do that, right? But at least for a little bit, taking their clothes off so I can see. Right? I might not be able to feel bruising, or if they're unconscious, maybe they can't tell me that something hurts when I palpate it, when I touch it. So I have to be able to see some of these things, or maybe there's bruising, or maybe there's obvious deformity or something that was hiding underneath a sweatshirt or clothes. So this doesn't mean that they're naked for the whole rest of the time. I can cut their clothes off and then kind of cover them back up after I've seen it. Right? Obviously, we want to protect their dignity and things like that as well. Right? But at this point, once we get to the chest, we're going to get our patients trauma naked. Right? We're going to cut the clothes off, basically, if we need to. So we have to expose the patient so we can observe them correctly. We get down to the abdomen. We're going to be looking for distension, pulsating masses, and rigidity as well. We're going to be feeling all four quadrants. And then what's important to remember when we're doing this, and the mistake that people make, is that they're just pressing down like on the abdomen, right? They don't check the flanks, the sides. And so it's important to check the sides as well. So we're going to palpate all four quadrants and check the sides there as well. Looking for distension, pulsating masses, and rigidity. And we're going to do the rapid assessment of the pelvis. What we're looking for in the pelvis here is any signs of bleeding, so bruising, things like that. So we need to see that. Again, trauma naked, we're going to be seeing everything here. We're going to be looking for what's called a priapism in men. This is for men only. Priapism is an erection, and it can be a sign of spinal trauma. So if you have, that guy that got hit by a bus, and for some reason your patient who has this is a multi-system trauma patient, however they're erect, right? That's a sign of a spinal injury. It's not the sign that that they're actually aroused, right? You'd have to be a special kind of person to get hit by a bus and have that happen. But it's a sign of a spinal injury, not of anything else. So we're looking for priapisms there. And what we're really looking for with the pelvis here, I really gotta do this thing up. What we're really looking for the pelvis there is stability. It's stability of the pelvis. Pelvic injuries can be incredibly painful, and so it'll change the way we can move a patient if we know that there's like a hip fracture, pelvic fracture, or something like that, dislocation, things like that. So it's important to check this. And what we're doing is we're going to be grabbing the patient by the hips, basically. And we're going to kind of squeeze up and in, right? Like we're closing a really big book. We're just going to up and in like that, okay? Real simple. And we just do it once. If they report pain, we do this up and in on their hips like that. And they let us know that it hurts in some way, right? We don't do it again. Make the injury worse. We don't want to put them in pain, any more pain than we absolutely have to, so we're just going to do it once. If they report pain, take it as a positive finding that the pelvis is unstable. And then we're going to do the rapid assessment of the extremities. We're going to palpate all the way down, right? Again, we're looking for DCAT BTLS in all of this, but there's three things that we're looking for specifically on the extremities. and that's called PMS or CMS, whatever you want to call it. Used to be PMS, now people are calling it CMS. It means the same exact thing. PMS is pulse, motor function, and sensory function. Right? So if I'm doing a rapid trauma assessment down somebody's arm, I'm going to, with both hands, I'm going to feel down their arm, looking for DCAP, BTLS, and all that. I'm going to check a pulse when I get down here to make sure that circulation is there or pulse is there, right? For PMS, checking for pulse. For CMS, we're checking for circulation. I don't think some people could handle calling PMS because it has something to do with, women's health there. But it's the same thing. So we're looking for pulse or circulation, PMS or CMS, same thing. Right? Then we're looking for motor function. Can you wiggle your fingers? Can you wiggle your toes? Can you lift your feet up? Can you push them down? That kind of thing. Right? So checking for pulse, checking for motor. Obviously, asking somebody to wiggle their fingers really only applies to somebody that is conscious, but just in case they're unconscious, we'll ask just in case. Hey, can you wiggle this? Probably expecting no answer coming from an unconscious person, but just go ahead and ask them. So pulse, motor function, and then sensory. Can you feel this? If they're looking away, what finger am I touching? Right? If they're like, what? You're not touching a finger. When you're touching a finger, that's a pretty good sign that there's neurological impairment there, right? Not getting nerve function back to the brain somehow. So we want to see, one, that we're getting circulation down to the very ends of the extremities, and that also our nerve pathways going from the extremity to the brain are good, and the nerve pathways from the brain to the extremity are good, right? So from the extremity to the brain is sensory pathways, from the brain out to the extremity, that's the motor pathways. So we want to make sure all those things are good. So for each extremity, both arms, both legs, we're going to check for PMS or CMS. After we get done, all right, so that's head to toe, right? And your patient is probably going to be laying in the anatomical position, right? Flat on their back, head in a neutral position, arms outstretched, legs outstretched. We've gotten the entire front and sides of their body, but we haven't gotten their back yet. So what we're going to do at this point is we're going to log roll the patient over towards us, and we can check down their back. As they're rolled onto their side, we can check down their back, down the backs of their back, their butt, down the backs of their legs, that kind of thing. And as we're doing this, we're going to combine this with putting them on the backboard at the same time. So I'm going to roll them over onto their side. I'm going to slide the backboard in, and then we're going to roll them back over onto the backboard, and then they're all set to become immobilized. The whole time while we're doing this, if we've taken manual stabilization of C-spine, that person is in charge of the roll, of the count, when we roll back, all that kind of stuff, things that we've discussed and shown in class. All right, once we've gotten this done, once we've gotten the rapid trauma assessment done on this multi-system, high priority trauma patient, then we'll get our vital signs, and then we start in our past medical history, if we're able to, and then we'll start our treatment. Okay. Here's a picture of a guy. He's having a rapid trauma assessment done. Obviously, we've got somebody holding C-spine. The collar is already on. They rolled him onto his side. Backboard's in position. And you can see he's checking the back of his back right there, his posterior, to check for injuries. All right, so for some general principles, be open with your communication about your patient. It's not very often that people have their clothes cut off against their will, right? If it was me, I wouldn't care, but if I'm really hurt, yeah, who cares? Cut off my clothes. Look at it. Make me better. Make me feel better, right? But it can be really disconcerting having your clothes cut off. It's a situation. 911's there. You're in the back of an ambulance or on scene. You're really hurt. Now all of a sudden you're getting naked in front of a bunch of strangers. It's going to be very uncomfortable for that person. So we need to kind of put ourselves in their shoes a little bit and explain these kind of things. Like, hey, I'm going to cut off your shirt. I need to be able to look at your chest for any injuries here. I need to be able to see it. I'm going to cover you up right when I'm done. Okay, I promise I'll protect your dignity and things like that. Okay, so it's important to be open, honest, communicate with that patient freely about what you're doing. Okay, I promise you that it is always better to communicate with your patient, let them know what's going on. They may not like what you're saying, about their injury or illness or things like that, but they will feel better knowing what's happening to them, right? What you're doing, what you're looking for, that kind of thing. There's nothing wrong with talking to your patient. This is one of the new things that some new EMTs struggle with, is talking with this patient like an actual human being rather than a commodity, like a thing. Here's this person. It's not even a person anymore. It's a thing with these injuries, and I have to do all these steps and blah, blah, blah. One of the first things that new EMTs forget is to just talk to your patient like a human being. It will be a better patient for you if you can accomplish that. It makes life easier for everybody. Always expose an injured area before you examine it there. So make sure you're examining that. Maintain eye contact when you're talking with them. Obviously, just general nonverbal communication things there. Another general principle here in treating traumatic patients is that sometimes we should assume the worst based on their mechanism of injuries, and then walk it back as we discover how hurt they are. You don't want to go into it doing the opposite. Let's say you have a big rollover crash or multi-car pileup or something like that. Everybody should be fine. And it's like, whoa, well, maybe there's broken bones, and then there's cuts and bleeding and all this kind of stuff, and it gets worse and worse. And we need to assume that things are worse or very bad at the very beginning, and then we can walk it back as we discover that maybe, hopefully, it's not as bad. So if you have a big mechanism of injury, things like that, assume there's the spinal injury. It's a safe way to go. Assume there's a spinal injury, and then rule it out later with your assessment. So assume that person, then I'm going to rule it out. Now, we may have to stop or alter our assessment process to provide care. And what this means is that if you find an injury that needs treatment right now versus continuing with your assessment, then stop and do that treatment. It's always preferred. Now, when we're talking about these things, it's generally life threats that we're talking about. So if you're, say you're getting somebody trauma naked and you don't see all the blood that's been held inside their jeans, like their pants, right? That can hold a lot of blood in there. And then it's like, oh my gosh, this is a really big bleed that they have down here. So if you find that, then it's like, okay, instead of continuing on with my evaluation, my assessment, I'm going to stop this bleed, and then I'm going to continue on with doing it. So you may need to stop and alter your process there based on your findings. All right, so here is showing some assessment of the PMS or CMS there. So checking the pulse again, looking for movement. You can get some flexion of the wrist there. Equal grip strength, right? Just have them put up 2 fingers, have them grab on, say squeeze them real hard, and it only has to happen for a second. They don't have to hurt you, but just have them squeeze real hard for a second, so you can test. There should be the grip should be even, the strength should be even here. So we got to do this all places, So please remember that we have 2 pulses down on the foot. You should know what they're called and where to find them. All right, for pediatrics, here we got to remember that it doesn't take as much to hurt a kid sometimes as it does an adult. All right, so age again can come in and be a factor. So lesser mechanisms of injuries can cause more significant damage to kids. So we have to be aware of that. When we're assessing kids, it's real important to explain things to them. They're good. Kids are going to be a better patient for you if they're involved in the process and they kind of understand what's going on a little bit. So if you're explaining what you're doing and maybe what you're looking for and things like that, that can help. Kids are notoriously bad patients because they're not good reporters for themselves, meaning they might not tell us exactly the truth because maybe they think they're going to get in trouble for however they got hurt. Maybe they were doing something they weren't supposed to, or maybe they just think they're going to get in trouble because they got hurt and now there's an ambulance there. Now there's these strangers here and mom and dad are upset, right? So they may not be the best patient. So talk to them. You want to kind of gain their trust and things like that. When we're doing a rapid trauma assessment on a patient to make sure that the patient is comfortable with pediatric, with younger kids, instead of starting at the head and working your way down, we're going to start at the toes and work our way up. Okay. All right, so what we do here, what criteria would you think you'd use to decide whether or not to do a focused physical exam or a rapid trauma assessment? Now, to remind you, a focused physical exam is just on the area that's injured. Rapid trauma assessment is a head-to-toe assessment. What do you think? What could tell you to go one way versus the other? Well, that focused physical exam it's used for patients without significant mechanism of injury, right? More of a minor kind of injury. We can just kind of focus on that. We're not worried about other areas being hurt, right? Rapid trauma, it's for severely injured patients or unconscious trauma patients. And so they have a severe mechanism of injury. If they're unconscious, they can't tell us what's hurting, that kind of thing. So it's either not significant or significant means life threat. Okay, it's either not an immediate life threat, so one place, it's not a significant mechanism of injury, or it is a significant mechanism of injury, they're unconscious. Those kind of things there. All right, let's see here. All right, let's touch on the detailed physical exam here. All right. The detailed physical exam is just that. It's detailed. It's slower. It's more in depth. We have time to really take a look at things here rather than just, oh, that's an injury. Let me catalog it here. Detailed physical exam. Like I said, we take our time with it. It's typically completed en route to the hospital because with trauma patients, we have less time. They're usually more urgent. And so you don't spend a lot of time on scene. And especially doing a detailed physical exam, we can do that on the way to the hospital, to get any other information that we might need. The detailed physical exam, it complements, as it says here, the primary and secondary assessments, in that we'll redo everything, basically. We'll take our time, check back in on our ABCs, make sure everything's good, make sure the chief complaint is the same. We'll check in on our priority. Again here, are we still at the same priority level? Do we need to adjust it up, down, whatever it might be? And then we're going to take the information that we gathered, all that detective work that we've already done. We're going to take it and then we're going to apply it to going through this more thoroughly and more carefully. again, we've already done our primary assessment. We've already done our secondary assessment. We've already treated any life threats should there be any. All right. So all of our critical steps here have already been taken care of by the time we get to a detailed physical exam. As we said, we are going to redo our primary assessment as part of this. Right? So we're going to recheck in, make sure all our findings for ABCs are good when we do this. All right, trauma patient with a significant injury. You'll have assessed pretty much the entire body here. And when we get to the detailed assessment, we're going to be doing it more thoroughly. Again, that rapid trauma assessment only takes like a minute and a half to get the entire body done. All right. What that entails is speed. And so we may miss minor things or some things. And so we were going to go thoroughly through the whole body afterwards. We're going to go nice and slow all the way through. A couple extra things that we need to look for, which we'll learn about there. But we're looking for anything that we may have missed or things that may have changed. Injuries can get worse over time, right? So we're going to look for things that have changed or things that we may have missed in this very detailed, like fine-tooth comb going through it. Again, detailed exam, we may not be able to get this done, all right, based on how much is going on. But if we've gotten our primary assessment done, we've gotten a rapid trauma assessment done, then we can take the time that we need en route to the hospital, again, to get these things done. Like I said, if we can get this done, it's appropriate. If it's not appropriate to get it done because of time constraints, because of the injuries, because of the nature of the injuries or what's going on with the patient, the manpower that's available to you at that time may not be adequate to complete treatments for the patient and then get the detailed assessment done. So if we can get it done, it's great. If it's not, if we can't get it done because we're doing other things, then that's okay. That's okay. Much like getting that second set of vitals. Sometimes if we're just too busy, or or getting repeat vitals, extra sets, we just may not be able to because of limitations of time or manpower or whatever you might have there. Again, this goes along with what I'm saying. To give the best care possible, we may not be able to do a detailed physical exam, right? If we have to work on life threats, if we're maintaining an airway, if we're breathing for the patient, things like that, then we may not have time to do this, and that's okay, right? This isn't ever really going to be the priority to get done. We'll need to get this done if we can, but it's not like, I got to do my detailed assessment. I can't recheck my ABCs. ABCs is always going to take priority on that stuff, right? If we can get this done, cool. We got to make sure everything else is done first. So ABCs, primary and secondary assessment. So we're going to re-expose the patient. So if we've already cut their clothes off, we can just, hopefully we just cover them back up or cover them with the sheet. We're going to re-expose it. We're going to take a look again. Hopefully, if there's injuries, we've already immobilized it, things like that, right? We're not going to be taking things off that we've already put on them. Like if we put them on the backboard, I'm not taking them off the backboard to check their back again, right? I'm going to work around that kind of equipment that's there as best that we can. The components are similar to the rapid trauma exam. You're basically looking for the same things. We're going for a very much slower pace. And there's a couple of finer points that we're going to look for here. It's a little bit more detailed, a little bit more focused. All right, let's talk about the trauma patient who's, for the detail exam, that it's not significantly injured. They generally don't need a detailed exam head to toe for the non-significant injury. We can just do the focused exam where that injury has occurred. And we've talked about this before, the index of suspicion. This is like your feeling about whether or not there are more injuries there, or whether it could be serious injuries, right? If you have a high index of suspicion, right, you go to a car crash scene and the car is just a crumpled ball of metal, right? Your index of suspicion for injuries, right? I suspect this patient has injuries, that kind of thing, should be very high based on the appearance of the car, right? So anytime there's injury, have an index of suspicion, right? A high index of suspicion. Always think it's worse. We can always come away from that, right? We can always back down from that. Okay, you don't want to be caught off guard by an injury. We want to kind of think that, oh, maybe that could happen there, and then realize, okay, maybe, all right, that injury did not happen in this case. Okay, we can move on from that. So keeping a high index of suspicion is important about all that stuff. This is an important point to note that, listen, when somebody gets hurt bad enough that they need us to come to their scene, they're probably going to need a bit of emotional support there. People get scared when they get hurt. They're thinking, like, did their life just change in a significant way for either days, weeks, months, years, the rest of their life? Right? They may be really concerned about all this stuff. They may not have the educational background, the medical training and expertise that you're going to have to know what's going on. You can help comfort them. You can assuage some of their fears. You can provide some emotional support for them. In a real simple way, again, it's just talking to these people. Again, new EMTs, new medical providers in general, even people that are in nursing school or medical school, becoming doctors or nurses who have not had patient care, one of the things they have to learn is, you gotta remember that people that are hurt or really sick, they're still people, and you can still talk to them like people. They're not just, cattle. They're not an object. They're not a product or something that we're working with. It's an actual person. So not only are we there to do things like diagnose and diagnose injuries, fix life threats, things like that, we can provide a lot of support just by talking to them like a human being. So that's important. Be aware of that. All right. That's where we'll end up today. Here, so just a quick overview. Patient without significant mechanism of injury. Look at the history of the present illness and a focused exam, a physical exam that's focused on their chief complaint, where they're actually injured. They're focused where they're injured based on their chief complaint and the mechanism of injury. All right, that's what we're looking about there. Patients with, and then we'll do that focused exam, and then we'll get the baseline vitals and the past medical history. Patient with a significant injury or with a significant mechanism of injury, we're going to take C-spine, right? Manual stabilization, probably call for ALS, get a very brief history of the present illness, and then do our rapid trauma assessment. After we get that done, then we can do things like history of the past medical history and vital signs, things like that. Again, in doing the rapid trauma assessment, we're looking for DCAP, BTLS, deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. These are all important to know. We need to know that front to back. It's not just good enough to say I'm looking for DCAP BTLS. You got to know what DCAP BTLS is, frankly. So you should be able to say it. So start practicing saying deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. All right, cool. We're going to stop there. If you have any questions, please email me. The next video for the rest of this chapter will be up shortly. Again, if you have any questions, let me know. See you guys.